You walk into a hospital to get better, but you might walk out with an infection worse than what you came in for. Every year, 1.7 million Americans get infections in hospitals, and 99,000 die from them. These aren't accidents. They're preventable. C. diff, the superbug living on every surface. Clostridioides difficile is the infection hospitals fear most because it's nearly impossible to kill. C. diff forms spores that survive on surfaces for months. Standard hand sanitizer doesn't work. Most disinfectants don't work. It's living on bed rails, call buttons, IV poles, and bathroom fixtures right now. C. diff causes severe diarrhea, abdominal pain, fever, and in worst cases, toxic megacolon requiring emergency surgery. Once you get it, there's a 20 to 30% chance it comes back even after treatment. Here's what makes it terrifying. Antibiotics cause C. diff. The very drugs treating your infection wipe out your good gut bacteria, creating the perfect environment for C. diff to take over. Hospital rooms aren't properly decontaminated between patients. Studies show that cleaned rooms still have bodily fluids and bacteria on surfaces. The 15-minute turnover between patients isn't enough time for proper disinfection. Healthcare workers spread it between patients. Their hands touch contaminated surfaces, then touch you, your food tray, your medications. Even with hand-washing protocols, compliance rates are only 40 to 60%. If you develop diarrhea in the hospital, demand C. diff testing immediately. Ask if your room was terminally cleaned with bleach or UV light after the previous patient. MRSA, the flesh-eating bacteria in hospital beds. Methicillin-resistant Staphylococcus aureus is a staph infection that's resistant to most antibiotics. It lives on skin, in noses, and on every surface in hospitals. About 2% of the population carries MRSA without knowing it. MRSA causes skin infections that look like spider bites initially, red, swollen, painful, but it can invade deeper, causing pneumonia, bloodstream infections, and surgical site infections. Invasive MRSA has a mortality rate of 10 to 30% even with treatment. You're most vulnerable if you have surgical incisions, IV lines, catheters, or open wounds. MRSA loves entry points. Healthcare workers carry MRSA on their clothes, stethoscopes, and phones. That doctor who examined 3 patients before you without changing their white coat? They're a walking MRSA vector. Hospital curtains between beds are rarely washed and are constantly touched by contaminated hands. Bed rails, call buttons, TV remotes, all MRSA reservoirs. If you're starting to realize hospitals are more dangerous than you thought, hit that subscribe button. We're exposing the infections they hide and how to protect yourself. VRE, the silent colonizer. Vancomycin-resistant Enterococcus is a gut bacteria that's developed resistance to vancomycin, one of the antibiotics of last resort. VRE colonizes your intestines and can live there for months or years without causing symptoms. You become a carrier, spreading it to others. When VRE does cause infection, it's usually urinary tract infections, bloodstream infections, or wound infections. The problem is that treatment options are extremely limited. VRE spreads through the fecal-oral route. Contaminated hands touch surfaces, those surfaces are touched by others, and eventually bacteria reach mouths. Hospital bathrooms are VRE hotspots. Roommates of VRE-positive patients have up to 40% chance of colonization. The isolation precautions hospitals claim to implement often aren't followed properly. The terrifying part is that you can be colonized with VRE and never know it unless specifically tested. You could leave the hospital carrying drug-resistant bacteria. Bedbugs. The infestation nobody admits. Hospitals have bedbug problems, but they'll never tell you. Bedbugs travel on clothing, bags, and medical equipment. They hide in mattress seams, furniture cracks, and electrical outlets. They feed at night, leaving itchy bites in lines or clusters. While bedbugs don't transmit disease, the psychological trauma and secondary infections from scratching are significant. More importantly, discovering bedbugs means facility-wide infestation that's being hidden. Hospitals treat bedbug reports as public relations disasters rather than patient safety issues. They'll quietly move you to another room and deny any widespread problem. If you see small brown insects, tiny blood spots on sheets, or dark spots on mattress seams, Document with photos and report to administration in writing. Bring minimal belongings to hospitals and keep everything in sealed plastic bags. Never place bags on the floor or furniture. Surgical site infections, the preventable tragedy. Between 2 to 5% of surgical patients develop infections at incision sites. That's 300,000 to 500,000 Americans annually, many entirely preventable through proper protocols. Surgical site infections occur when bacteria enter during surgery or recovery. They cause redness, swelling, pain, pus, fever, and can require additional surgeries. Deep infections can destroy tissue or cause sepsis and death. Here's the dirty secret. Surgeon technique and operating room sterility vary wildly. Some surgeons are meticulous about sterile fields, others get lazy. Post-surgical wound care is where hospitals often fail. Nurses should change dressings with sterile technique, but time constraints lead to shortcuts. If your surgical site becomes increasingly painful, red, swollen, or starts draining after surgery, demand immediate evaluation and wound cultures. If you're realizing you need to protect yourself in hospitals, subscribe now. We're teaching you how to avoid these infections and what questions to ask. Catheter-associated urinary tract infections. Urinary catheters are infection highways directly into your bladder. CAUTIS account for over 30% of all hospital-acquired infections. The longer a catheter stays in, the higher your infection risk. Bacteria climb up the catheter, establishing bladder infections that can ascend to kidneys or bloodstream. Catheter-associated bloodstream infections have mortality rates of 10 to 25%. Here's the problem. Catheters are overused. Many patients get them for staff convenience, not medical necessity. It's easier for nurses to manage a catheterized patient than help them to the bathroom. If you have a catheter, ask daily if it's still medically necessary. Request removal as soon as possible. Central line infections, when IV access becomes deadly. Central venous catheters provide critical access for medications, but they're direct portways for bacteria into your bloodstream. Central line-associated bloodstream infections kill up to 25% of patients who develop them. Studies show that proper insertion technique can reduce infection rates by over 60%. This means using full sterile barriers. Yet many facilities skip these steps to save time. If you need a central line, watch the insertion and demand full sterile precautions. Question whether you truly need a central line or if a regular IV would suffice. How to protect yourself. The best defense is aggressive hygiene and informed vigilance. Wash your hands obsessively before eating, after bathroom use, after anyone touches you. Use soap and water for 20 seconds because sanitizer doesn't kill diff spores. Demand that everyone touching you washes hands in your presence. Don't be polite about this. Your life is more important than their feelings. Bring your own disinfecting wipes and clean high-touch surfaces yourself. Bed rails, call buttons, phone, TV remote, bedside table. Minimize catheter and IV line duration. Question medical necessity daily. Hospitals cause 1.7 million infections annually because infection control protocols aren't consistently followed. The bacteria are there, waiting. Your best defense is knowledge and vigilance. Don't trust that hospitals will protect you. Protect yourself.